Okay, anything you just make a note and then we will go to the next topic. What are the differences between basic life support and advanced cardiac life support?
BLS is done in outside the hospital, sir. ACLS done inside the hospital.
BLS, supposing a patient falls in the corridor of a hospital, cannot somebody
Done
do
by
a
paramedics.
Paramedic.
Paramedics are
it
public.
can be done by medic for paramedic. Supposing you are in a hospital and patient falls down with the cardiac arrest in the corridor, if a nurse who is going that way, they can attend on the patient. Whereas if it is in a public mall, you go to EA mall or Forum mall, and there somebody falls with a cardiac arrest, then the public only have to attend, lay public. Okay, so BLS can be done by both medic and paramedic or lay public, whereas advanced life support is mainly done by medical people. Okay, that is the first and foremost difference. Then
BLS does not include placement of advanced airway.
very good. Can they give drugs? Can they give adrenaline to resist
No,
it?
sir. Only in ACLS.
Mainly targeted on compression only life support, sir.
Okay, then supposing there is an AED machine, and somebody knows how to use it, that can also be used. Okay, they cannot do manual defibrillation like what you do, putting the paddle and then pressing. But if it is an automatic machine which will instruct, tell all the instructions will be written there in the box, and one has to simply follow the instructions given. And once you switch on the machine, it will automatically shout yes, shock. Then the patient can automatically it will deliver the shock itself. Isn't it? So AED can be used, but not manual defibrillation. So it is mainly for CPR, artificial ventilation. They can give mouth to mouth or even bag mask ventilation. Some oxygen administration, if it is available. Basic airway management. Sometimes BLS includes also spinal immobilization. People are taught how to keep the patients quietly, and you can just monitor the major pulses like carotids. Bandaging and splinting have been taught in people who are trained in BLS. It is used in obstetrics. Some people know how to do glucose monitoring with the glucometer, albuterol treatments also. And this is the emergency medical treatment for paramedic advanced life support. They should know how to do the EKG monitoring. They should know how to do defibrillation, manual defibrillation, advanced airway management, external pacing also, fluid therapy, needle chest compression, and administration of medications. So these are all the things which a BLS person cannot do. Okay. So another way of describing it is more non-invasive, no medication, and can be done by anyone trained or even lay person. It can be two persons or a single person, and no right to give basic treatment. Whereas ACLS, it is a more of invasive. You put a tube, you put an LNA along with medications. You can give a stimulant like adrenaline or amiodarone, and it is usually done by medical personnel who are specialized, and defibrillator in the manual mode is used, and it is teamwork by so many people, and it is not only for cardiac, it can be for other injuries also. Okay. So what are all the core concepts of basic life support? One is airway, breathing, circulation, defibrillation, and differential diagnosis. So these are the differences between the ABCD approach. That is what we call between the ACLS and BCLS. Now, adult cardiac arrest algorithm. This is the 2020 guidelines. Every 5 years they change or give recommendations. So 2015 was there, then 2020 is there, and there are slight modifications done every year, but the major modifications are done only once in 5 years. And so, how should the compression be, and what should be the rate according to the latest guidelines of adult cardiac arrest algorithm? What
30,
should be
To
the
120
depth?
compression per minute.
100
Depth
to
of
120 range.
at least 5 centimeter
Ah,
or 1/3 of the anteroposterior diameter.
that is for children.
Children.
1/3 of the anteroposterior for pediatric. This adult is always to
5
5
centimeter.
5
At least
centimeters.
5 centimeter, and the rate should be 100 to 120 per minute.
100 to 120. Right. So what is the compression respiration ratio with or without advanced airway?
30 is to 2.
30 is to
30 is
2.
to
30 is to 2. Very good. Okay. What monitor is recommended to assess the quality of CPR in the guidelines?
Capnography,
TCUD.
Capnography, intra-arterial pressure monitoring.
arterial line, arterial wave.
Serial line is the what energy is recommended for defibrillation?
Monophasic 360 joules, biphasic 120 to 200 joules.
200. Okay. So what are the drugs used during CPR?
Adrenaline,
Adrenaline,
amiodarone, lignocaine.
Midorone, and
Adrenaline, when will you use adrenaline? When will you use lignocaine? When will you use
ACE,
amiodarone?
asystole or pulseless electrical activity, adrenaline.
Very good. How much?
1 milligram.
1 milligram.
1 is to 1000. 1 is to 1000
1 ml of
concentration.
1000.
That is 1:1000
For
is
every
the
5 minutes.
concentration. Every 3 to 5 minutes.
5
Okay.
minutes.
If there is no response. Okay.
Ventricular tachycardia, ventricular filtration.
Lignocaine for VT and the amiodarone for.
Sir,
So what
route
gadgets
of
are used
administration.
for?
Route of administration, sir. Adrenaline.
That will also come in the algorithm. Yes.
Intrava-
Supposing you have, what are all the routes of administration of adrenaline? Adam is asking.
Intravenous, intraosseous, endotracheal, sir.
Intravenous, intraosseous. Can you give
Intraosseous.
intracardiac?
No, sir.
2020.
Not
Even some very many years ago, we used to do intracardiac, but now it is completely banned. Nobody should give intracardiac adrenaline. Intravenous, intratracheal, or intraosseous in children. Of course, even in adult, it may be difficult. What are the gadgets are used for advanced airway?
Sorry, LNA,
Robotic airway device, endotracheal device.
Can be supraglottic or endotracheal intubation.
Device.
Only two. Okay. How is their correct placement confirmed?
So capnography.
Capnography, sir.
Capnography. Very good. What is the rate of respiration if you have an
10
advanced
10
airway?
breaths per minute.
10 per minute. 10 reps per
Every
minute.
6 seconds. What are the indicators of return of spontaneous circulation?
There is a
Rise in ETC
patient
water levels.
response.
More than
Increase in the
35 to
increase
40
what we
millimeters
get
of mercury.
Only one at a time. I'm not able to clearly hear you.
Abrupt rise in ETC water levels. More than 40 millimeter of 35 to 40 millimeter of mercury.
Okay, very good.
With return of pulse rate and BPs. Blood pressure.
BP. So all cardiovascular also you must say. What are the reversible causes of sudden cardiac arrest?
PH5D.
It's a 5T.
IHS5. Okay, very good. So the entire thing is here. What all you said, what are all how the questions are there. So push hard at least 2 inches. That is 5 centimeter for adult. Whereas in children only 1/3 of the anteroposterior diameter, and the rate should be 100 to 150. Allow complete chest recoil. This is very, very important. You should not be going on pressing 2 inches and push the sternum towards the vertebra and collapse it. Okay. In those days, we were taught that you should break at least 3 ribs. Then only you are doing a successful CPR. That is not permitted nowadays. So just correct compression and allow sufficient time for recoil also, and minimize interruptions in the compression and avoid excessive ventilation. Do not allow the other person to ventilate too much, and change compressor every 2 minutes. So if your 2% resuscitation is being done, one person should look after the respiration. Then after 2 minutes, that person should start the CPR, and the person doing CP compression should go to the head end and start ventilating. So every 2 minutes they should change. And it is a cycle of 30:2. It is 30 compressions and 2 ventilation. Like that, it will be 5 cycles. And after that, you give an interruption and check whether there is any palpable pulse or any increase in the ETCO2, all that. So this is one cycle is 30:2. Like that, 5 cycles, then only interruption should be done. And ETCO2 is considered as the correct method of checking your quality of CPR. Okay, how good you are doing it. And the shock is always preferable will be biphasic with 100 to 200, 120 to 200, and in monophasic 360. And drug therapy, epinephrine IV or intraosseous, the dose of 1 milligram every 3 to 5 minutes. Amidrone IV or intraosseous again, first dose 300 milligram, second dose 150. Or lignocaine in cases of PTAC should be 1 to 1.5 milligram, second dose 0.5 to 75 milligram. And advanced airway ET tube insertion or supraglottic airway devices. And once the advanced airway is there, then you go for 1 breath every 6 seconds or 10 breaths per minute. That is the rate of respiration. And once the patient has a secure return of consciousness, there is a pulse and a blood pressure. We are able to palpate a pulse, and there is a sustained increase in the ETCO2. So ETCO2 graph should be sustained. It should not suddenly disappear and then reappear. And spontaneous arterial pressure waveforms if you have an intra-arterial line monitoring. And of course, the reversible causes are 5 H's: hypovolemia, hypoxia, acidosis, hydrogen intoxication, hyperkalemia, hypothermia. And the keys are tension pneumothorax, tamponade, toxin, thrombosis in the pulmonary circulation or coronary. And this is the algorithm flow chart. How you do every step, you ask whether there is a return or not, then proceed like that. This is the same thing in the flow chart model. This is the 2020 American Heart Association guidelines. Okay. Now coming to adult post cardiac arrest care rhythm. What are all the things that you should do after the patient has been successfully revived? They all for that also they have an algorithm that also has guidelines. So the question is, what are the recommendations for respiratory and hemodynamic management after return of spontaneous circulation?
So respiration, ventilation, breath should be 10 per minute with saturation to be maintained at around 90 to 96, and PCO2 target 35 and 42, between 35 and 45. And BP, mean arterial pressure, should be maintained more than 65, with systolic BP more than 90 millimeter mercury.
Okay. So this is the resuscitation of ongoing person, airway management, waveform capnography, management of respiratory parameters. Saturation should be 92 to 98. And start with 10 breaths, titrate PCO2 between 35 and 40. So you must mention SpO2 value also. And manage hemodynamic parameters, administer crystalloid and or vasopressor or inotrope to maintain a systolic blood pressure more than 90 and a mean arterial pressure of more than 65. Okay. MAP 65, SBP is more than 90. So these are the parameters that you have to maintain. What are the continued and additional management that you should do after the initial cardiorespiratory resuscitation?
If the
Targeted temperature management.
Investigations,
Depending
ECG.
on the neurological recovery, the answer is that. So there, the answer is the evaluation should be done concurrently, so that decision on targeted temperature management receive high priority as cardiac interventions. So emergent cardiac interventions, early evaluation with a 12-lead electrocardiogram, consider hemodynamics for decision on cardiac intervention. Targeted temperature management if the patient is not following commands. So you first assess the neurological status. Start as early as possible the targeted temperature management. Begin at the temperature, cooling the patient to 32 to 36 degrees for 24 hours. The PTM should be only maximum for 24 hours using a cooling device with a feedback loop. And other critical care management, continuously monitor core temperature either at the esophageal, rectal or bladder level. Maintain normal oxygen, normal CO2, euglycemia. These three should be maintained correctly. Provide continuous or intermittent electroencephalogram, that is EEG monitoring. Provide lung protective ventilation. So these are all the additional managements with regard to saving the central nervous system or neurological function. So this is the flow chart. So initial stabilization, continued management. In the initial stabilization, you manage the airway, manage the respiratory parameters, manage the hemodynamic parameters. And then obtain 12 lead ECG, then consider emergent cardiac intervention if there is a STEMI present, that is ST elevation MA present. Consider doing a revascularization. If there is unstable cardiogenic shock or mechanical support required, if you all that, then check whether the patient is able to obey your commands. Check the GCS. Then find out whether if he is able to command, that means he is become awake. Just do the critical care management. Only patients who are not responding, who are comatose, immediately as early as possible, try to start the targeted temperature management. If necessary, obtain a CT scan, do an EEG monitoring and other critical management. And evaluate and treat rapidly reversible etiologies. Involve expert consultation for continued management. So these are all the things that have been given for post cardiac arrest algorithm. Now coming to pediatric cardiac arrest algorithm. What are the differences in CPR quality in pediatric patients compared to adults?
Rate 15:2, sir.
And
And
chest compression,
third,
not on chest, but it is about 1/3 of the anteroposterior diameter. Okay. So the
20 to 30 breaths per minute.
the rate is faster here,
Yes.
100 to 120. Allow complete chest recoil, minimize interruptions, change the compressor, same thing. And the airway cycle is only 15:2, not 30:2 as in adult. And provide continuous compression and give a breath every 2 to 3 seconds. Okay, so with the advanced airway, the respiratory rate is larger. It is not every 6 seconds, but it is only almost double. It will be roughly 20 breaths per minute. Whereas in adult, it is only 10 breaths per minute. Okay, so the compression power is reduced to 1/3 of the anterior posterior diameter. The cycles, instead of 30:2, it is 15:2. And with the advanced airway in place, the number of breaths are more compared to adults. Okay, so these are the differences. What shock energy is recommended in pediatric patients?
Initial
Adults
shock,
will be
2 joules per
typically
kg.
say or 20 to 2.
per kg.
2 joules per kg.
Initial 2
Yeah,
to 4.
2 joules per kg. Second shock, 4 joules.
4 joule per kg, maximum up to 10 joules, sir.
10 joules.
10 joules. Yeah, very good. Right. Then what is the drug dose in children? Adrenaline, how much?
10 mics.
1 ml of is to 10,000.
No, what
1
is
ml
body
kg.
weight kg per how many milligrams or micrograms per kg is always the answer in children. So the dose is 0.01 milligram. That is 10 mics per kg. Maximum dose 1 milligram. Repeat every 3 to 5 minutes, either through IV or intraosseous or endotracheal 0.1 milligram. Endotracheal administration is 10 times more than the intravenous or intraosseous. And then amidrone, instead of 300 milligram bolus, it is 5 milligram per kg body weight as the first dose. Then subsequently you can repeat the same dose up to 3 doses. Whereas in adults you start with 300, then continue 150, second dose. Whereas in adult children, 5 milligram per kg first bolus, then you can repeat the same dose 3 times. And lidocaine, you give 1 milligram per kg loading dose. Normally you don't repeat it in children. What airway gauges are used in children? It's the same endotracheal tube and LMA or anything else?
Only
Huh? Supraglottic airway. Both the same. Just like adult, you can use an ET tube or a supraglottic airway. And waveform capnography confirm the position of the ET tube. This is again a flow chart that you would do all these things. Whatever written here in the printed form, it is followed here. Okay, so epinephrine dose is not given here. It is given only 3 to 5 minutes, but the dose is 10 microgram. It is easy to remember because 1 milligram is 1000 microgram. So it is easy to dilute in that way rather than taking a 0.1 ml like that. So better dilute it in correct way to give it.